Chapter 31. Chapter 31 covers mental illness and behavioral emergencies, which is if I dare to say, a nearly epidemic in the United States. We tend to have a huge number of mental illness issues and behavioral emergencies. Not nearly as much in EMS, although we have plenty of those, as they do. The emergency rooms are just constantly flooded with these. It's just a revolving door of patients in, patients out with behavioral and psychological emergencies. They're clogging our ERs, and unfortunately there's not a whole heck of a lot that can be done about it with the current system. But they certainly do have their fair share of time reaching out for EMS, particularly when law enforcement doesn't know what to do with them. They call us, or sometimes it's called in as something like an overdose or suicidal ideation, whatnot. As with all the chapters, simply listening and watching this lecture is no replacement to reading and studying the chapter, so do that at your earliest convenience if you have not already. We're still running off the theme of the AEMT will be able to apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely ill patient. So we are wrapping up the medical emergency section this week, so we'll start to see that kind of change then to the acutely injured patient. We have a multimedia video about applying restraints. You have a handful or two or three or four actually of objectives on pages 714 and 715. All right, so EMS providers are often uncomfortable managing patients with mental illness and behavioral emergencies. We don't understand them. There's not as much concrete evidence. There's not as much easy to interpret pathophysiology that goes along with behavioral and psychological emergencies. It's just they're difficult for us to comprehend, and there's not much we can do about it. And it makes us feel helpless. We have to use our interpersonal skills and our therapeutic communication in order to reach out to the patient, and often that's the extent of what we can do for them. It's just trying to gain their trust and try to get them to go willingly with us to the emergency department. Otherwise, it ends up being kind of an ugly situation where people get taken into protective custody, potentially even forcefully restrained, and made to go into the emergency departments. We always have the potential for it to be an unsafe scene when we're dealing with behavioral emergencies. Critical patients may need airway, breathing, and circulation. However, that doesn't alleviate the potential for violence, for the potential for there to be people who have a 180-degree swing in their behavior in a matter of seconds. A lot of distraught patients have a hopeless feel, and then if they're feeling hopeless, they really don't care about what's going on around them. So they don't care that striking you as a medical provider, is a crime. So there are many medical legal considerations about consent and restraint. Sometimes when the patient is not within their right mind making appropriate decisions, then we consider the fact that they may not be able to give true consent. Not to mention restraint. Restraint, when we have to restrain a patient, is definitely a high-stakes situation. There's potential for people to get hurt. There's potential for people to get killed, particularly the patient dying in the process. Not to mention, are we taking this patient without appropriate consent? So involving law enforcement and medical control both in making these decisions helps to make sure everybody can put their 2 cents in and determine that this is the best best course of action. And then we also have ethical considerations. There's a lot of things that we may hear that aren't necessarily kosher in our society. So you think about it, goes with your case study. Mental illness is an emotional or mental state of dysfunction, and it may or may not be apparent. There are many, many people who deal with mental illness on a regular basis that you would never know otherwise. Many EMS providers suffer from a minor mental illness because of a lot of the traumatic stuff we see, PTSDs, sometimes anxieties or depressions, and it's job related. So there are plenty of people who are on antidepressants or anti-anxiety medications that you would not know otherwise. So facial expressions, posture, actions, words, all those things can kind of tip us off, but not necessarily. Sometimes we may treat a mental illness patient for a different medical emergency and have absolutely no idea that they had any mental illness, other than they told us they potentially told us when we were doing their history, or we detected it when we looked at their medications. Oftentimes when our specific call is for a behavioral emergency, it's usually quite a bit more obvious because we have those actions that this person is doing or things they're discussing or talking about makes things a lot clearer. This is truly a behavioral emergency. So there are lots of different mental illnesses out there, far more than we can truly even comprehend and understand fully. We can have things such as anxiety or depression. We can kind of throw them together and have bipolar disease. We have stress reactions such as PTSD. We have personality disorders, which people may have some underlying medical condition that's causing some changes in their personality. Otherwise, it may just be a chemical issue. Psychotic disorders, in which the patient has completely bizarre behaviors. Addictive behaviors, things such as even eating disorders can be classified as behavioral emergencies. So they're not all over the top things like schizophrenia or people that are institutionalized crazy. There are plenty of people who are functionally crazy. So what defines a behavioral emergency? A behavioral emergency is when a person's actions and behaviors no longer fit the acceptance for society or themselves in general. So when a person is doing something that society finds objectionable, or really honestly, if that person themselves would find that objectionable, that can be a behavioral emergency. So patients with mental illness cannot be grouped together any more than patients with other medical problems. Everybody has such a different route of where they got to, and everybody has such a different way that they cope and handle and are being treated for their issues. Sometimes it's strictly some outpatient therapy. Maybe it's also things such as medications. Maybe they even go in for electroconvulsive treatment, or basically electric shock therapy. Sometimes it's inpatient, very intense institutionalization. A lot of times it's really more outpatient. Sometimes people are just learning to get coping skills. So it's so very, very different. And then the mental illnesses are extremely diverse. They range from anxiety to depression, stress reactions, and so on and so forth. So we have all these different potential reactions, and sometimes they compound this issue because people have more than one. It's kind of like medical problems where people might have COPD and CHF all in one. There are some keys, though, that we look for when dealing with some of these issues, such as indications for impending violence, because that disrupts the scene safety. That puts us in danger. Law enforcement, that's part of their job, is to deal with the unsafe scenes. Us in EMS, we deal with patients and provide them with health care. We generally keep ourselves out of the line of fire because when the medic goes down and there's nobody else to take care of anybody else, crap just got real. So the cops, if they get shot, they want to make sure we're there. So some things that you may look for: increased fidgeting or restlessness, pacing, profanity, loud voice, yelling, screaming, destructive behavior where they're destroying stuff or attempting to, clenched fists, increased muscle tension. Even sometimes you look at their jaw and you can note that it's clenched. Threats, intoxication, signs of past violence. History can be huge because it seems like many times we go to the same patients over and over again for very similar situations. EMS being requested often means that the element of violence or impending violence, the potential for there to be violence. Oftentimes law enforcement has been on scene for a while before we get there, unless it's something that we get called for that's actually started out medical in nature. So if it started out overdose, with suicidal ideation of some sort, we probably get called pretty quickly. But in many cases, for something that people are acting out, they probably are going to try to get law enforcement there. Law enforcement's probably going to try to get them talked down and whatnot before they even have to result in calling us. Law enforcement may also get on scene and identify, hey, there's the potential for this to be a medical emergency. Because remember, some of our medical emergencies, diabetic reactions, strokes, overdoses, many of those can mimic an intoxication, mimic a behavioral emergency. So the alterations in mental status, they're maybe anxious and responding with inappropriate behaviors and inappropriate wordage, that sort of thing can throw people. So law enforcement is likely to want EMS to be there to just check the patient out quickly to make sure that there is nothing else going on there. We may need to restrain the patient to prevent him from hurting himself and or us or others. And our scene safety is paramount and must remain dynamic. We have to constantly be looking for and considering how ugly could this scene get. We need to be constantly aware and looking for, do we have an escape route? If something goes wrong here, the patient takes a lunge at me, can I get my butt out that door before that patient gets between me and the door? So we're going to maintain a confident but relaxed approach. If we go in there all chest puffed out and big and bad, all we're going to do is compound the situation. We're going in there basically with an approach where we're trying to gain their trust and we're trying to be there and be empathetic and help them with their situation. We're much more likely to get them to respond and get them to participate voluntarily with some of the things that we're doing. You have to consider that patient's affect, their posture, their movements, and their behaviors. Look at what they're doing. Is there the potential for there to be weapons around? Are they constantly going over to one particular area? Is there something on top of that dresser that they're keeping their eye on? Look at how they're responding. Are they their affect? Are they crying? Are they screaming? Are they mad? What is it that we're really getting from their behavior and their appearance? Posture, more of a slumped over posture. It's kind of a feeling of hopelessness where, if they're puffed out, their arms they have clenched hands and whatnot. It's generally a little better clue that, hey, this person probably has some anger issues that they're dealing with right now. Look at the general living conditions. In many cases, things have been bad for a while, and when things have been bad for a while, then their living conditions tend to suffer. We may be living in complete squalor, maybe have things all destroyed in the house, whereas we may walk into a beautiful home that's just almost immaculately kept, and we have one room where this patient has been recently that's been destroyed. That could tell you a little bit, is that this isn't the norm, what I'm seeing in this room, from what we typically have going on in this environment. Look beyond the obvious to determine whether the patient may have attempted to harm themselves. So you got to kind of scan the room, look around, maybe have other people look around the scene. Do we see things like empty pill bottles? Do we have bottles of alcohol, evidence of illicit drugs, ropes, knives, guns? Maybe have somebody go check out the garage. Is the vehicle running out in the garage? It's all kinds of different things we have to consider as this patient made any attempt on their life. In most cases, if a patient has what's deemed a credible suicidal ideation, even speaking of it, not even have to actually do anything, that usually is going to get them a 48 to 72 hour hold for psychiatric evaluation. If they're unresponsive, confirm that unresponsiveness. Be careful. If you had reason to be suspicious of behavioral emergency to begin with, that quick swing in the situation can quickly end up being ugly for you. Do they have a knife underneath them? Do they have a gun underneath them? So we're going to confirm unresponsiveness, check for a carotid pulse, begin the CPR protocol as necessary, AEDs, controlling significant hemorrhages. For that responsive patient, continue to be constantly bouncing back to scene safety and respect that patient's personal space. It goes back to therapeutic communication a bit, where we talked about, where are you appropriately distanced from the patient? And in most cases, 3 to 4 feet away is considered a fairly close personal space. So backing yourself up a little further than that gets you out of arm's range as well. And hopefully you can talk with your patient and have enough time to react and respond should that patient make a lunge for you. History and secondary, being empathetic and non-judgmental in your approach is essential. Sometimes we got to tell them, look, we're not law enforcement. We don't care what you did. We just want to get you some help. We want to make sure you're safe and you're healthy and you're okay. If we have an alteration in mental status, if we can, check a blood glucose. Remember, this is alteration in mental status is the key symptom or sign in the patient with a diabetic reaction. So we can have people become extremely violent when they're hypoglycemic. And I've seen this with a number of patients, that as long as their glucose is within a normal range, they are the nicest people you'll ever meet. But you get them a little hypoglycemic, and we're going to fight. And it's very embarrassing to the patients, and many times, because that's not really who they are. List of medications is extremely important. There's often many medications that these people are on. Some of these medications can have some very negative side effects. We're going to get to those here really on the next slide. And then interview the family, the friends, the bystanders. If we can try to do a lot of this separately, it really gives us a better picture as opposed to everybody chiming in at the same time. It kind of builds a muddled picture. So if we can look at, because some family members may have sensitive information that not all the family members have. So when we look at some of these medications, there's a lot of antidepressants in this world, tons and tons and tons of them in the world here. In fact, some of the top-selling drugs in the world are antidepressants. In fact, for a long time, Prozac, fluoxetine, was the #1 selling drug. So we have citalopram, sertraline, paroxetine, escitalopram, venlafaxine, duloxetine, bupropion, trazodone, desvenlafaxine. So you're seeing kind of a commonality here, the INEs or the LINEs or the TINEs that typically go with the antidepressants. Most of those are in a class of either a select serotonin reuptake inhibitor or a select norepinephrine reuptake inhibitor. We talked about those a few chapters back. So those are commonalities that we see. We have some that don't quite fit the mold there, the trazodones, the bupropions, and some of these also, remember, have multiple uses, such as bupropion or Wellbutrin is commonly used in smoking cessation. So we can't always pigeonhole them based off of their meds, but the more of these they have, the greater chance that you're dealing with a person with mental illness. St. John's wort, that's an herbal remedy that's said to help people with depression. We have some antipsychotic agents such as chlorpromazine, haloperidol, clozapine, risperidone, olanzapine, quetiapine, ziprasidone, and aripiprazole. So the penes tend to have more antipsychotics, so clozapine, olanzapine, quetiapine. So the antipsychotics are really more for people who are beyond depressed. They're really maybe having more psychotic episodes where they have where they're acting out. And then we have some other medications that get used for mental disorders: lithium, clonazepam or Klonopin, lorazepam, alprazolam, diazepam for that matter goes in there, buspirone, propranolol, valproic acid, carbamazepine, gabapentin. So we see that the AM drugs, either the PAMs or the LAMs, and those are fitting in the benzodiazepine category. So they're related to Valium and Versed, so they're sedatives. Lithium is for people who have pretty severe schizophrenia. And then some of the others are just kind of supplementary. Now there's a drug class that they don't list on here that's at least worth mentioning, and that's the drug class of the cyclic antidepressants, tricyclic antidepressants. So amitriptyline, nortriptyline, Elavil, those drugs are an older class of antidepressant. They still sometimes get used when these newer ones don't work. The problem with those drugs is people that overdose on cyclic antidepressants, particularly tricyclic antidepressants, those people can go from living and kicking 1 second to in cardiac arrest and asystolic the next. So overdoses on the cyclic antidepressants are of a particular concern, and that's definitely, if you're strongly suspicious of it, you should definitely consider getting ALS coming soon. Because you may have, or getting paramedics coming soon, because you may have to do a little more work here than you're ready to do. So we can do a brief mental status exam and MSE here. Things that we're going to look for: their level of responsiveness. Of course, this isn't nothing new, as well as their orientation. Those things are things we get on every question or every patient that we can, because we're looking for brain function and how does the D in our ABCDs, how's the D working out here? Looking for their ability to sustain attention and concentrate. Sometimes this will be off because of the nature and the severity of their medical problem that they're dealing with. But in most cases, what's referred to as flight of thought, where they're just kind of zipping around. A lot of times we'll like to joke, oh, look, that's ADD, and you're talking to a patient. Next thing you know, a squirrel runs by, and all of a sudden the patient off on another tangent. Disorders of perception. So what do they think they see? What do they think they're dealing with? So do we have some things such as hallucinations? Is the patient seeing things? Is the patient hearing things? Do they think people are after them? So do they have things such as paranoias? Any disordered thinking? Is their thought process on track with how normal life goes, or is it, are they talking about things like, oh, well, the mothership's coming down for me? Affect and mood. How are they acting when we talk to them? Are they generally happy? Are they upset? Are they mad and screaming their responses back to us? Or do they have a very flat affect? A flat affect is that monotone, don't show any emotion in their discussions with you. And then their behavior. What sort of things are they doing? Are they doing repetitive things? Are they packing a bag? Are they and when they're packing a bag, what are they packing in this bag? What sort of things have they done? Have they, stored up food in their room because the world's going to end? Kind of paranoia behaviors on top of their paranoid thinking. We also have to look at things such as we have to use our clinical reasoning to kind of gather a lot of this information. Can it be something that is medically related? And if it is, we need to probably consider moving fairly quickly on that because it's affecting the D, or the disability dysfunction. So the brain is not functioning well here. Could we have a traumatic cause? So could the patient have fallen recently, now has a small head bleed in there, and that's causing some changes in their behaviors? The chief complaint may or may not be related to their history of mental illness. They may be complaining of a headache. They may be complaining of purple elephants in their bedroom. So one of those is obviously related directly to their mental illness. The other is perhaps not. So maybe it's things like changes in their vital signs. Some of the antidepressants can have changes in vital signs. Slow you down or speed you up. People who are changing medications sometimes have some pretty negative side effects, such as dizziness and whatnot. We have to be cautious of any diagnostic error because of the history of mental illness. The current problem may be due to mental illness, but in many cases it's not. Remember, that diabetic, that maybe the overdose, maybe it's not even an intentional overdose. Maybe it's an accidental overdose. That happens. So problems that may present as a behavioral emergency. Infection, so they're basically becoming toxic. Tumors, neurologic damage from substance abuse. A lot of times patients will have very strange behaviors because their brain basically rewired during some substance abuse. Recent or past traumatic brain injury. Some people go from living very, very normal lifestyles, get brain injury, and now they become incredibly psychotic, or they become incredibly violent people. Strokes, same sort of thing. Seizures, the seizure, they could have kind of a lip smacking, facial tic thing going on that you think, what the heck's going on with this person? Are they on drugs? But it ends up being just a seizure. Endocrine emergencies, where we're talking about changes in blood sugar levels, we're talking thyroid conditions, adrenal conditions. We change up the hormones, we can see a lot of odd behaviors pop up. Hypoxia, metabolic disturbances such as sepsis, and then drugs and toxins. So treatment and reassessment. Therapeutic communication is usually about the extent of it. We don't have lots of fancy medications and procedures that we get to use in behavioral emergency. So in many cases, it's talking. If they've injured themselves, if they have a medical condition going on, we're going to try to address those things. So maybe they've made what I call them chicken scratches, but where the person kind of rubs a knife back and forth on their wrist. They don't actually make any cuts, but they're kind of hesitating. We may need to treat some things like that. Establish the baseline for the patient's condition. You may not get that from this patient. You're probably going to have to get that from other people on the scene that are familiar with this patient. And then if the patient is physically restrained, we have to assess them as soon as the restraint is accomplished and very, very frequently thereafter. Restraining a patient puts a lot of undue stress on them. It puts a lot of stress on us as well. So we have to be very, very cautious when we're going to go the route of restraining patients. So make a clinical impression of the mental illness as a cause only after assessing for medical and traumatic causes. So do not overlook the significance of unexplained vital signs or other exam findings as a potential indication of medical or traumatic emergency. So most people with a behavioral emergency, sure, they're probably going to have a little elevation in blood pressure, a little elevation in heart rate, maybe a little elevation in respiratory rate. But if we have an over the top, their blood pressure is 230 over 150, and their heart rate's 180, 190, 200 beats a minute. Those are things that we got to consider as potentially medical issues underlying. When people get upset, sure, those things are going to change a little bit, but that's to the extreme. All right, so anxiety disorders. Excessive anxiety can interfere with social and occupational functioning and can be harmful. People can have things that get as ugly as, say, panic disorders or unreasonable phobias. Usually everybody has something that they're a little afraid of, a little scared of. Mine just happens to be heights. So there are people who have unrealistic phobias. So say somebody that would be afraid of heights of, being more than a foot off the ground, and that would create an over-the-top behavioral emergency. You can have panic disorders or panic attacks, obsessive compulsive disorders where maybe they have to wash their hands 10 times in a row every time they touch a doorknob. They're constantly cleaning, they're straightening out the fringe on their rugs. They just constantly go back over and back over and back over, sorting their silverware. They can have acute stress reactions. Many times that's related to PTSD, where we have people who are with these acute stress reactions. They're kind of panic-stricken. It's similar to a panic disorder as well. So there are, remember, a few things that also go along with as causes of panic or panic-like disorders or anxiety-like disorders: shocks, MIs, adrenal disorders, asthma, certain substance abuses will often give you appearances of anxiety disorders, or sometimes it will start to kind of cause them. So they can either mimic them or they can cause them. So it's kind of a slippery slope. People who are hyped up on caffeine, too many Red Bulls, that easily can throw you towards an anxiety disorder. So signs and symptoms: they may have tachycardia, chest pain, chest tightness, or discomfort. They may have tachypnea, diaphoresis, a sensation of choking or being suffocated. So with those, a feeling of impending doom, I think I failed to say that one. With those signs and symptoms, if you didn't know we were talking about anxiety disorders, you didn't know we were in the behavioral emergencies chapter, and I told you they have tachycardia, chest discomfort, tachypnea, some fear, some feeling of impending doom, diaphoresis, sensation of choking or suffocation, you could very easily say, well, that's a cardiac patient. And you probably could be right. But it may simply be a anxiety disorder. The problem here is we really can't sort the two out in the field, and in many cases we end up punting and treating what appears to be the worst of the two evils. If we have an anxiety problem, if it goes untreated, generally they just remain anxious for a while. If we have a cardiac event, an ACS going on, and it goes untreated, we could have a cardiac arrest. So that's why we tend to punt and go with the worst of the two evils there. So like I said, things such as shock, myocardial infarction, hyperthyroidism, adrenal disorders, so on and so forth, can cause the same symptoms, or sometimes some of these things will bring it on. Cocaine overdose. huge. Cocaine overdose is just, cocaine's a stimulant. It's going to stimulate a lot of anxieties in most people. Gives people kind of that rush and that boost that they might be looking for. Yet cocaine is one of the biggest offenders when it comes to bringing young people in with cardiac events, because cocaine is overstimulates the heart. So panic attacks are brief periods of intense fear, anxiety, and discomfort. They may feel like they're going to die. They may feel like they're going to pass out. They're having a heart attack. They're losing control. They have a sensation of unreality. So they're basically depersonalizing. Panic attacks can go with many of these different anxiety disorders, typically with the panic disorder, but really any of them may potentially have these panic attacks. Usually within about 5 to 10 minutes, they start coming down off of that panic attack, but they're very susceptible to swinging right back into another one. So try to help them focus on calming down, slowing down their breathing. Use some of those relaxation techniques we've all learned. Slow, deep breaths, in through the nose, out through the mouth, so on and so forth. And try to reassure them. We don't know for sure that it's going to pass, but just try to be comforting for these people. And then, again, we really have to be careful when we're dealing with patients with some anxiety, because it so easily could be a medical emergency. And we have people who, one of the first complaints that we look at when we look at their lists of signs and symptoms is anxiety or changes in mental status. So we have some cognitive disorders or disorders of thinking. We have delirium and dementia. We've talked about these before, but it's in the neurologic chapter, but it's worth repeating here. Remember that delirium is an acute onset of confusional state with underlying correctable causes. So in many cases when we have patients who have overdosed on certain medications, maybe they have a metabolic problem, something's out of whack, they may have a diabetic reaction going on, those sorts of things can cause some deliriums. Dementia, on the other hand, is a progressive and permanent deterioration in their mental function, usually also including memory impairment. Both involve confusion that can lead to fear and combative behavior because they can't perceive and respond to their environment. So delirium is a short-term thing. Dementia is a permanent long-term thing. Both of them, let's see, the patient's age should not be a factor when evaluating the risk to your safety. I have seen plenty of people who are nursing home bound, generally fairly weak patients, but for some reason they have a bout of delirium and they become superhuman strength. Okay, you can't keep them down, and a lot of times they try to kind of put them in jerry chairs and try to protect them for their own safety with some of these vests as a sort of a restraint. But in many cases, it's not even enough. They find ways. So don't let that kind of control your perception of the situation. Eating disorders. We have patients with eating disorders, a very common mental health issue. In many cases, we are completely unaware that patients may have this until it's later in the ball game, because they get good. They get very good at hiding some of these things. Whether or not it's actually our views on beauty in the world today or the United States today, or something else, there's obviously a reason why people are looking to change their outlook. So the three common eating disorders we discussed are anorexia nervosa, bulimia nervosa, and then binge eating. So anorexia is not eating, bulimia is eating and purging, and then binge eating would be the other end of the spectrum, where they just take off and just start chowing down on everything in sight. So the populations that are most prevalent for these eating disorders are typically young females, those that are still kind of trying to find their personal their personality or their personal style, they're trying to come into their own. So patients with anorexia nervosa eventually get to the point in which they are extremely thin and look emaciated. Emaciated is the term for underfed. They are obsessed with losing weight, typically, and controlling their food intake. They put themselves on these dietary restrictions where they're always counting those calories. They may have very specific things. They're only going to eat 3 grapes and drink 3 gallons of water today. That might be what they consider a healthy diet. They many times will be exercising constantly, where even they might be doing exercise while they're trying to do other things. They're getting out of class and going and running around the building real quick to try to get a little bit more exercise in and burn off more calories. Laxative use is very common amongst them, as is diuretics. We try to remove that excess amounts of weight. Remember that water weighs 8.8 pounds per gallon when it's pure water. So that can actually take off quite a bit if we can take a quart or a half gallon off. They're probably going to try to induce vomiting to prevent weight gain as well. However, it's not their typical MO to induce vomiting, where bulimia it is. So patients with bulimia often are of normal weight, but they're obsessed with losing weight, and they have the repeat cycle of binge eating, and then they take measures to counteract it. So the exercise, diet, the vomiting, the laxatives, the diuretics. In many cases, they often will kind of progress from maybe bulimia into anorexia. And then patients with binge eating disorder are generally obese, not followed by an attempt to lose weight. They're okay with that. One thing that you can kind of identify people who, particularly bulimics, who are making themselves vomit or purge, you look at their teeth and you look at their knuckles, because their teeth over long periods of time will show signs of acid erosion from vomiting. So it thins the teeth, it kind of stains and discolors the teeth. And then their knuckles, in many cases, they're trying to stick their first 2 fingers down their throat to stimulate their gag reflex, and a lot of times it'll scrape them up when they drag across their teeth. So those are things to look for. You could also look for things such as some minor chemical burns around their mouth, simply from the fact that they're vomiting so much. Remember, people who are vomiting on a regular basis are prone to some issues of the throat and the esophagus, such as Mallory-Weiss tears or esophageal varices. So they have the potential where they could have some pretty severe bleeding. Mallory-Weiss, which the tears were named for, had an eating disorder, and so that was she got it named in her honor for being one of the first patients they identified this with. So, number of people in the U.S. with an eating disorder, either anorexia or bulimia, is 10 million females to 1 million males. So, sufferers are often well informed about the physical risks, but they get stuck in the loop. They get stuck in the cycle and really can't break free. They know that they're not doing the healthy things for their body, but their mind is telling them to do otherwise. And then there are websites out there now that are supporting and encouraging eating disorders, so which is kind of frightening. There are some chat rooms out there where there'll be particularly girls, but also boys, where they'll behind their name put either Anna or Leah. Anna for anorexic, Leah for bulimic. So it kind of helps identify what their MO is, or what their disorder is, where they can kind of discuss ways actually to get sicker, I guess. It's difficult for people to understand, but so factitious disorders and somatoform disorders. Factitious disorders, they're intentional infliction of either physical or psychological signs or symptoms, either to oneself or to others. The biggest factitious disorders we talk about are Munchausen's and Munchausen's by proxy. So Munchausen's is when we have people who are calling us for their whatever medical problem that they actually don't even have. So they're trying to basically get us there to show attention. So they kind of get off on the attention they get from healthcare. So when the firemen show up and the EMS shows up and law enforcement shows up, all the people in the ER that are working, it gives them, kind of I guess a moral boost, a psychological boost, that there's all those people there caring for them. Munchausen's by proxy, that's when somebody does something to one of their loved ones to gain attention. Sometimes it's kind of to get the attention that, hey, you were the hero, but in many cases they're kind of living in the glory and of all the attention. So this is when moms bring babies in. Oh, my baby stopped breathing. My baby stopped breathing. Once in a while, they actually cause physical harm to their loved ones, or themselves. I mean, they could certainly frequently try to cut their own wrists. They could frequently try to smother their baby, make their baby stop breathing, all to bring on some of this attention. Somatoform disorders are physical symptoms without apparent physiologic cause. So the somatoforms, people with hypochondriasis, which is being a hypochondriac. You think that there's something wrong with you because you see something. I think this is probably really starting to take off a little more with the advent of people self-diagnosing with the internet. The internet can be a great tool for information. However, we have people who are taking it on saying, oh, I have this, and taking it to the extreme. These people are typically very preoccupied that they have a serious or life-threatening illness, and their concerns will continue despite us giving them the reassurance and negative assessment that doesn't support what they're claiming or what they think is going on with their body. A conversion disorder is a sudden loss of specific neurologic function following a severe stressor. So they may have pseudo-seizures, they may have sudden onset of paralysis or sudden blindness, they may stop talking. Those are examples of conversion disorders. I think a great example of, you have to love stupid sophomore comedy, but in Talladega Nights, when Ricky Bobby wrecks his race car and then thinks he's on fire, and then he thinks that he is paralyzed and in a wheelchair. That would be some examples, albeit comical, of conversion disorder. And then body dysmorphic disorder. They're preoccupied with the physical defect that's not apparent to others. So these are the people who go on with the ridiculous numbers of plastic surgeries. The people who are addicted to plastic surgery is common body dysmorphic disorder. They feel something on them isn't quite right. And this very well could go along with an eating disorder. So Factitious disorders, there's no external gain from the behavior. If the external gain exists, the behavior is considered malingering instead. So, to obtain symptoms, patients often will inject themselves or ingest toxins, contaminants, in order to try to produce false signs and symptoms by contaminating their urine samples with blood, report false events such as syncopes or seizures. Impulse control disorders. These are certain control impulses that make certain behaviors that are generally unacceptable to society. Things such as kleptomania, pyromania, gambling, intermittent explosive disorder, or angry outbursts. Not a lot of times do we actually get called for many of these, with the exception of the anger outbursts. Those would potentially raise some eyebrows in the public arena, and would potentially be called for a behavioral emergency. All right, the diagnosis of these is a psychiatric condition, and the act that results from the disorder is often a criminal behavior. So pyromania, kleptomania, gambling, all of those typically are criminal. In the cases of repeated fire setting, pyromania and arson are sometimes used interchangeably, but pyromania is a medical diagnosis and arson is actually the criminal term. So they're not the same, but they're connected and related. Mood disorders. So people with mood disorders, they can have major depressive episodes where they'll swing into a depressed mode. They have very decreased interest in things once found pleasurable. Food, sex, hobbies, those sorts of things. They may have extreme weight gain or extreme weight loss because maybe they have lost the interest in food, or maybe they're trying to replace something that they feel is missing with food. They may have insomnia where they can't sleep, or they have excessive sleeping, and increased or decreased psychomotor activity. So they may just be sitting around doing nothing. On the other hand, people can be extremely active during times. So they're losing weight, they're not sleeping, they're up, they're running around, they're doing lots of stuff, all as a sign of a major depressive episode. So it's often kind of a misnomer to believe that people, once they get into a rut, are just going to sit, gain weight, and sleep all the time. It's kind of a misconception. It seems that the majority of them actually do follow that. Often will also express feelings of worthlessness, potentially even guilt. They regret some of their actions. They will often have inability to think, concentrate, and make appropriate decisions. Their mind is kind of all in a mush, and they may or may not have thoughts of death or suicide. Just because somebody's depressed does not mean that they are suicidal. I think a lot of people at one time or another probably, they maybe wouldn't admit it, but had probably considered that at some point, but didn't ever really go farther than saying, what if? Bipolar disorder. Bipolar disorder only affects less than 1% of the population. It's periods of persistent, abnormally elevated mood interspersed with periods of depression. So they kind of have the swinging affect here. So when they're up, they're up. They're 100 miles an hour. They're doing everything in sight. Maybe just go nonstop for days on end. And then the pendulum swings the other way, and now they're depressed. They won't get out of bed. They won't eat anything. They won't do anything. A lot of times people who are bipolar are on medications such as antipsychotics and antidepressants, anti-anxiety agents, potentially even anticonvulsants, and then lithium in the worst occasions which is a mood stabilizer. Most of the people that are on lithium are schizophrenic. But it's bipolar disorder is a similar appearance. Okay, so unlike many mental illnesses, depression is prevalent in several age groups. So children, older children typically, adolescents and young adults, and then middle-aged adults and elderly all suffer from depression most commonly. Adolescents and younger adults, they just typically they feel like they haven't fit in yet. They don't fit in with society. They're having a hard time blossoming into their own person, whereas with the middle-aged adults and the elderly, they're now starting to suffer from some medical issues. Maybe they've started to lose some of their loved ones, and that all tends to drive some of that depression. Okay, so some personality disorders. There's several subgroups of personality disorders. Cluster A disorders, these are people that are emotionally distant, isolated, often with odd or eccentric behavior. So maybe you have the crazy hoarder person that kind of walks around town, doesn't really interact with anybody, always picking up pop cans, always picking up whatever trash they can, and they take it home and they kind of hoard it. Type B disorders, this is the emotional instability, impulsiveness. They have very intense behaviors for relationships. So they often will be a little bit more on the wild side, do a little bit more dangerous stuff. And then we have the cluster C disorders, which are the anxiety and fear disorders. So the over-the-top obsessive compulsive disorders, the extreme phobias that can fit into the personality disorders. Oftentimes anybody in the personality disorder spectrum is instantly kind of pigeonholed because of some of the things that they do. A lot of times things are socially objectionable. So personality disorder patients are ill-equipped to function in society. So they can have a very difficult time maintaining jobs and relationships because they're over the top. Maybe you have been in a relationship with somebody who, you were in a relationship from the very first date you went on, and if you didn't text them back within 30 seconds, they were all over you. What did I do wrong? I'm sorry. Don't leave me. That sort of thing. It can be a sign of, it's not an automatic, but it can be a sign of some personality disorders. And a typical lack of insight into their behavior. They tend not to perceive themselves as having a problem, but it's usually everybody else is the problem. So if you only would do this, if you only would do that, that's the way they kind of see some of those things. Schizophrenia. Schizophrenia and the related disorders. These are people who have really lost contact with reality. So these are people that are much more delusional. They have the mood swings in many cases, but really aren't able to function in everyday society without assistance. So they'll have very disorganized thoughts and behaviors. Many times they're very, very paranoid. The delusions that they have, there are people following them, that their house is bugged. They can have those hallucinations where they're either visual or auditory. They're talking back to some people that aren't even there. Occasionally they also have a very flat affect in which you're talking with this person and you get no emotion out of them. Very monotone again. So they have very impaired reasoning for what they believe. There's something going on of many kind, and like I mentioned many times, it's somebody's trying to get them, somebody's out to get them, and that's what is causing their behaviors and doing the things that they do. They can be very catatonic, in which they're apparently completely detached to the environment around them. Most schizophrenics are not violent. Their behavior just is so radical that most people really want to limit any exposure to them. An onset of schizophrenia is typically early adulthood. So this is something that adults can go for their entire life, basically dealing with schizophrenia. While most schizophrenics are not violent, the risk increases in patients who have hallucinations in which they believe they're being persecuted or commanded to do things. So I think we've all seen the horror movies in which there were demons telling them to do things. Very similar situation. They are not compliant with their medications. Many schizophrenic patients get to feeling better. They're on track with perhaps with their therapy as well as with their medications, and believe, okay, I'm cured. I don't have to take the medications anymore. And within a few days, they fall back into their rut that they've been in, and makes things pretty ugly. So a lot of times we end up going and picking these people up, take them in for evaluation, and they'll end up being on a psychiatric hold for a while they get their medications back in order and they get back leveled out again, and then they can typically function in society for a while, and then it's a matter of when's the next time that the shoe's going to drop. Many of them also have substance abuse problems, and that's when they can also become violent, because remember, not only are we now dealing with a psychiatric disorder, but now we're throwing toxins in on top of it. So diagnosis, the Diagnostic and Statistical Manual, DSM, 4TR of the American Psychological Association lists substance abuse as a mental illness, and addiction is a preoccupation with obtaining and using a particular substance with or without a physical dependence. Physical dependence is when your body relies on it to continue to function. Addiction is the mental state. We can have significant intoxication with CNS depressants such as alcohol or narcotics that can lead to respiratory depression, or even respiratory arrest and loss of the ability to maintain your own airway. So with that in mind, knowing some of the drugs, and we'll briefly talk about some of those drugs, but actually spend quite a bit more time on many of these substances in the next chapter, which is toxicology. Knowing their toxidrome, which is a term that you'll be introduced to in the next chapter. But so the toxidrome is the typical presentation for people who are under the influence of a certain class or family of medications. So knowing those toxidromes, the benzodiazepines, the opioids, the barbiturates, alcohol, all of those are CNS depressants. All of those can eventually lead to respiratory depression, arrest, and then finally cardiac arrest. One of the probably biggest opioid medications that is used illicitly or illegally is heroin. So heroin is similar to morphine, and it will cause very quick respiratory depression. So naloxone helps out with heroin, with the narcotics and the opioids. However, it doesn't help with the others. It does not help with the benzodiazepines such as Valium or Versed. Doesn't do anything to alcohol. Doesn't do anything to barbiturates. So addiction, substance abuse, and dependence often also have legal legal medications that are used. So it's becoming more of a growing trend where people are stealing prescription drugs, so it's technically illegal, or the person has such a dependence on these drugs that they were put on that they're now doing doctor shopping, where they're jumping from doctor to doctor, using 3 or 4 or 5 docs and 4 or 5 or 6 pharmacies to fill their meds. There's been some discussion on whether or not we should have a pharmacy registry and sharing of some of this health information, so they can say, hey, look, this person has seen 3 different doctors in the last 7 days and gotten 3 different prescriptions for this medication. Currently, nothing like that really truly exists. Now, of course, there's also those that are using illegal substances, the methamphetamine and illicit cocaines and marijuana in most of the states. So, and there's also the easily obtained substances such as alcohol and tobacco, which are the most commonly abused substances. The most commonly used quote-unquote drug in the United States is caffeine. I say that just as I take a big swig of coffee. So, substance abuse is defined in the terms of what is considered socially acceptable. Substance abuse is not illegal, but is still socially unacceptable. So, alcohol. Alcohol in beverage form is quickly absorbed via the stomach and the small intestines and metabolized in the liver. The effects of chronic alcohol abuse lead to things such as cirrhosis of the liver, alcoholic hepatitis, pancreatitis, gastrointestinal bleeding. You may have things such as a Mallory-Weiss tear or a esophageal varices for people who are chronic alcoholics and constantly retching. Very long-term effects of chronic alcohol abuse include things such as Wernicke and Korsakoff's syndrome. And Wernicke and Korsakoff's syndrome, Wernicke's is the earlier version of it, in which is basically withdrawal-like symptoms, and Korsakoff's is more related to long-term brain damage that's related to their excessive drinking. It's been associated with a lack of thiamine, which is a B vitamin. In some systems, paramedics will be pushing 100 milligrams of thiamine prior to giving D50 to patients that are either malnourished or patients who are suspected to be chronic alcoholics, because the lack of that B vitamin makes it much more difficult for them to appropriately use sugars. BAC is the blood alcohol concentration, and it's used to legally define intoxication. We in medicine use a whole number to describe what they in the legal field use as a decimal. So, for example, if we say a patient has an alcohol content of 80, that means they have a 0.08 blood alcohol content in legal terms. So a person who has a blood alcohol of 3 to 400, 0.3 to 0.4%, usually is unconsciousness, and most people over 400 or 0.4 result in death. Most people cannot handle that. It is not out of the question that people have higher blood alcohols than 400. I've seen them higher than that. I've actually seen them into the 500s. But those are people who are chronic, everyday super alcoholics. They don't usually last very long. Usually the effects of their alcoholism takes them out pretty quickly when they're starting to have such high blood alcohols, but they do build up the tolerance. So alcohol withdrawal Some symptoms that we might see of that: somebody who was unable to get their fix, tremors, headache, weakness, sweating, seizures, hallucinations, nightmares, delirium tremens, or what is called DTs. DTs begin about 48 to 72 hours after the last time they've had some alcohol, and it includes excessive anxieties, confusion, hallucinations. So many of what we're describing above there, and this dysfunction can actually lead to death from just being so much of an autonomic overstimulation. So alcohol withdrawals can be fatal. It's not a pretty thing, but a lot of times people have to be titrated downward in order to come down out of their alcohol dependence. So we're going to manage the airway, the breathing, and the circulation as best possible. Be alert for the possibility of vomiting and aspiration. Remember, these people will do just about anything to get their fix if they can't. So drinking things like rubbing alcohol. Rubbing alcohol is cheap. You can buy a big bottle of it at the drugstore for $1 or $2. You can get a quick drunk off of that. No, it doesn't taste good, but you get the intoxication that you're looking for. We have people who will drink cough syrups, people who drink mouthwash, people who drink various types of stove fuels. So we have stove fuels that get used for like camping stoves that are primarily an alcohol base. Sterno being one of those. Sterno is a liquid alcohol fuel that oftentimes they will filter through bread. Bread will help pull out some of the toxins that are in it, and bread's obviously fairly inexpensive to get your hands on. And they will filter it through bread and then drink what comes out the other side in order to give them their intoxication. Sometimes we have those patients, like I mentioned, that are we have patients who are suffering from some Wernicke's and Korsakoff's, people who are chronic alcoholics. Now remember, we can also burn up a lot of sugar when we're dealing with alcoholics, so they may become hypoglycemic. We may need to treat them with some D50. Alcoholics may require 100 milligrams of thiamine prior to their D50, and I mentioned that before. The chronic alcoholics and the people with eating disorders often need that boost in vitamins. Suicide. Suicide is the 8th leading cause of death in the U.S., 3rd leading cause of death in adolescents, and 90% of all patients who commit suicide have a pre-existing diagnosis of mental illness. Drug and alcohol abuse figures substantially into suicide. A lot of times they require something in order to kind of give them that push to go over the edge. Their methods and the lethality of suicide attempts vary by gender. Remember that most females are very concerned with doing things that are going to make them pretty in their casket. So doing things like hanging yourself, shooting yourself in the face, those sorts of things don't tend to be their MO. They just want to go to sleep and not wake up. So a lot of times it's going to be things such as trying to do drug overdoses or poisonings. Men, on the other hand, they just want to get her done. So in many cases it's going to be shotgun or something that's we're going to do some stabbing, something like that that's going to get the job done. White males account for 78% of all successful suicides, with 56% of them involving a firearm. Now, the rate of suicide in those 85 and older is 1.8 times that of the general population. So we also have the elderly population, which is now picking up on this because they've lost their spouse. They've been diagnosed with a terminal illness, and they don't want to go through with that. They don't want to put their family through that. After we ensure the scene is safe, we first manage any life threats, care for any behavioral, medical, or traumatic aspects, And then a suicidal attempt or suicidal ideation, the person can no longer cope with the situation and sees no alternatives. So a suicidal ideation may or not actually be the act of attempting. It may be just formulating the plan. So this is very, very common to see pop into the ER, these suicidal ideations. All right, now don't forget that death by suicide is a crime. It is a crime scene. So if we are called to one of these and we're actually taking actions to save the patient's life, we need to be cautious that we don't destroy evidence where possible. So if you have a hanging, don't cut through the knot. If you don't have any other option, of course, then you got to go through it. But if you can cut through the loop of the rope as opposed to the knot, a lot of times there's evidence that's preserved within the knot, and they'll look at the way that the knot actually was tied. Don't cut through any stab holes. Don't cut through any bullet holes. Cut around them because we can destroy evidence by doing that. The law enforcement and the medical examiner are going to have to investigate and make a ruling on the cause of death. So whether it's suicidal or accidental or natural or what have you, us being on that crime scene, potentially fouling the scene, can make that investigation much more difficult. And violent patients. So we'll have patients that have an increase of fidgeting or restlessness. They're pacing around, they use a lot of profanity, they'll have an increasing voice volume and have very destructive behaviors, oftentimes have clenched fists and potentially clenched jaws, and we may have to consider using restraint. Again, restraints should only be used in conjunction with law enforcement and preferably with medical controls advice as well. At the paramedic level, paramedics sometimes have the benefit of using a chemical restraint, so something such as a powerful sedative that can be used to get the patient to comply. Sometimes it's in a quick injection form that's given to the patient. Other times it may be something that is given inhaled up their nose. But in many cases, we actually end up having to go to a physical restraint or a tie down. So some key considerations when we make a decision to actually have to restrain a patient. Well, we have to think about how many people is it going to take for us to restrain this person. And in most cases, we want to use 5 people on one person, 1 for each extremity and 1 for the head, to kind of help control things. We need to understand what sort of devices we're going to use to physically restrain this person and how can we actually accomplish this, whether we use some cuffs, whether we use a soft set of restraints, maybe we have leather restraints. So we have to take into consideration how are we going to get the patient into these things, how are we going to approach, do we have any specific trigger that we're going to go on 3, who's going to have what. I mean, the plan has to be thought out very well ahead of time. Sometimes we are going to have to punt and use something like roll gauze. Roller gauze can be used to create some restraints. I've had to use handcuffs, have the law enforcement officers use handcuffs on the patient, and we'll try to use cotton belts and whatnot. One last thing to kind of consider and think about is the possibility of excited delirium, which we talked about in the neurologic chapter. We're not going to be hobbling or hog-tying people. We're not face downing them on things. We're not going to cover their mouth and nose tightly. If people are spitting, we prefer to use like a spit hood. Otherwise, we can use something like an oxygen mask. If we can put an oxygen mask on them and they can't get the mask off, they can spit all they want into that mask. We're still giving them O2. as long as we're able to remove it quickly. Should we have any vomiting, it's clear so we can see exactly what's going on there. We're not going to sandwich anybody between a backboard and the cot. Those are all situations in which can lead to excited delirium. The patient goes into a hyper sympathetic stimulation and spike a temperature and tachycardia, tachypnea, and start to develop some superhuman strength, and then eventually will, in many cases, expire. So we need to be very careful. We need to have policies and procedures in place. We need to make sure we have appropriate equipment to do this, and follow those policies and procedures when we can. All right, so behavioral emergencies can have situational, mental, and physical causes. Remember, they can also be related to a medical condition. Your safety, the patient's safety, the bystander's safety are all at risk. We're going to assess our patient for indications of an impending violence and request law enforcement as necessary. We're going to restrain the patient only to protect him from harming himself and others, and identify any potential medical or traumatic causes that are leading to this type of behavior and manage appropriately. And finally, the use of therapeutic communication is an essential element of our assessment and management, and a non-judgmental and empathetic approach should be the way that we try to handle most of these.